All right. Well, hi everyone. Welcome to another Q&A session with Dr. Grossman and myself. And this week we are so thrilled to be joined by a special guest, Dr. Carlo DiLorenzo. Welcome, Dr. DiLorenzo. We're pleased to have you. And we just spoke on our Twitter chat a few minutes ago today, but now we have you here with us on video. So Dr. Grossman, would you like to introduce our guest today?
Yeah, glad to. Hello, everybody. So Carlo, I think we've known each other for 20 years or so, going back to maybe Rome 2. Was that the first inroad back
Yeah,
in?
probably. Yeah, we go back 20 years at least. Yeah.
So Carlo DiLorenzo is the chief of pediatric GI at Nationwide Children's Hospital in Columbus, Ohio, part of Ohio State Medical System. And he's really been one of the leaders in what we now call disorders of gut-brain interaction, really spearheading the work of the Rome Foundation for Rome 2, 3, and 4. And we're very pleased to have him now. And we want to try to ask a few questions that come up from time to time. You ready for some?
Thank you for asking me to be here, and I'm looking forward to it.
Well, good. One of the things that I think comes up with adults is when we're talking about these disorders is how do we talk about stress and the brain-gut axis and explaining, getting around the issue, is this in my head or not? I think it might be different with an adolescent or a child. How do you explain that?
Yeah. Fortunately, I believe many people have experienced in daily life some degree of brain-gut dysregulation, right? It's not uncommon for people who are involved in sport or in school not to feel like eating much before a test or before an important game. People tend to have a change in bowel function at the same time. So those examples are actually resonates fairly easily with adolescents. I also tend to tell them that the belly is actually the mirror of the child's emotions. Grown-ups tend to get a lot more headaches, and kids tend to get a lot more belly aches when they are stressed and there is some anxiety. It's interesting because people tend to respect a lot more headaches and maybe worry a little less about headaches than belly aches. But in general, if you're able to bring up those daily life examples, they can understand that it doesn't take much for people to have GI symptoms.
I think we know about, I guess, what people call RAP, that children around school might get belly pain. And I think some guy wrote, do little belly achers become big belly achers?
Yeah, I'm not sure that that's completely true. Sometimes the phenotype changes quite a bit in adults. Some of them develop more of an anxiety problem. Others get better once they change the environment and they leave the home. But yes, I mean, the knowledge that any stress, including school, triggers a lot of GI symptoms in kids has been around since the 50s. John Apley published what you were just defining as recurrent abdominal pain, which was just a description. Kids were getting recurrent abdominal pain, a lot of belly aches. Now, fortunately, we are a little bit more sophisticated and we can make a diagnosis of functional abdominal pain, and we can explain it quite well. It's interesting that you were talking about school, because now with this pandemic, we all had the impression, our colleagues in Europe as well, and us, that we were getting a lot fewer calls about pain in children. And we actually are doing a study now trying to figure out if the fact that the children were actually staying at home without the stress or having to go to school led to a less symptom, or at least less disability. One of the main reasons why parents come to see us is the child that is afraid of going to school and has a lot of belly aches, and the school gets upset and they complain with the parents. But during the pandemic, from February to to now, there's been no school.
Yeah.
And, we had a lot fewer calls. Interesting.
How do the children like it at home?
Initially, I think actually most children kind of welcome not having to go to school. That's, it's a big generalization, but, many of them did. Once it became a little prolonged, you begin to do like 3, 4, 6 weeks, 8 weeks. Then I think I'm actually worried that we're going to see a lot of kids coming in with a lot of problems with worsening anxiety, maybe depression, and other sequelae of lack of socialization, that you miss all the interactions with your friends and miss all the age-appropriate activities. So I think we had probably a valley in anxiety, and now we may actually see a peak in anxiety, in the hands in GI problems as well.
Interesting. So
yeah.
when you're seeing the child or the adolescent with the parent, so the child is your patient.
Yeah.
Parent is sitting there with a list of items or something. How do you reconcile addressing the patient with the parent there, for better or for worse? I guess it could go both ways.
Yeah, that's one of the biggest challenges we have in pediatric GI, especially those of us that deal with a lot of functional disorder or disorders of gut-brain interaction, is the challenge is that often the agenda of the parents is completely different from the child. The parents are usually very concerned about a serious disease being present, and they expect, actually sometimes demand, some test. I still have to find a child that comes in hoping to get some test. The child almost always prefer not to have any test. So in trying to give in and trying to relieve parental anxiety, sometimes we make things worse in the child, because every test is somewhat painful, is scary and frightening, and it can cause all sorts of long-term consequences. So, one of the things that we usually say is that parental anxiety and physician insecurity determine the extent of the workup. So, you need to be able to relieve parental anxiety, because if the parents is worried, if the parents are catastrophizers, are worried that the child has cancer, or that has diverticulitis, or has a pancreatitis, whatever, then the child will not get better. The child will perceive parental worries, and there are plenty of studies that show that that's the case. And so our challenge is to to establish a good patient-physician relationship, having the parents trust us and explain things in a way they can understand, and maybe do a limited amount, very targeted amount of testing. I usually ask the parents, what are you worried about your child has? And maybe I do testing to relieve that worries. If they're worried about, I don't know, gallbladder disease or gallstones, I'll maybe do an abdominal ultrasound. They're worried about H. pylori, I may do a stool study for stool antigen and so on. So you've got to relieve parental anxiety without causing more anxiety in the child. And that's the art of doing something but not doing too much.
With adults, sometimes we'll see an adult come in with a parent, and the parent might want to pull me aside and say, let me tell you something about my daughter or my son. And I can usually deal with that by saying, well, why don't we say it all together? Because I'm basically saying, this is an adult patient who's my patient. It'll have to be in front of the other person, but you can't do that. What happens if you're confronted where the parent wants to kind of take control of the situation and see you separately?
Not that unusual. Even yesterday on telemedicine, I had a patient and the child, and the mom really wanted to talk to me without the child, and so she began to go from room to room with an iPhone, trying to find a safe and quiet place so the child would not hear. And sometimes it's appropriate. There may be things in the child history. Children who have had all sorts of tough life in the past, maybe abuse or maybe other issues that they don't want to bring up in front of the child. But eventually, we discuss what is okay to discuss with the child, how much does the child know and how much he remembers. So it really is based case by case. The other way is also true. Sometimes the child, especially if he's an adolescent, wants to tell me things that doesn't want the parents to hear. Right. All sorts of private issues. So it's not unusual for us to have some time with both of them, and then I will say, now it's time that I talk only to your child, and then I give them equal time and say, this is time for me to talk to you as well, alone without the child. Depends really what the issue is.
I like that.
Yeah.
So the child is now reaching 17 or so. They want to, the parent might initiate it. I don't know if the child would, if they have a good relationship with you, but the parent might say, we want to bring them to an adult doctor. What are the things you consider or address in that?
Yeah, the dreaded transition of care. Huh? I still need to find a division or a physician that says, oh, I do this really well. I think we all do a terrible job with transition of care. And I think our IBD folks have actually figured it out. I think a system that works pretty well. And the general principles are the same for everybody. You don't want to wait until the last minute. You want to introduce the topic when they are 16 or 17. You want to start maybe having sometimes the child come by himself, or maybe the parents just wait in the waiting area so that they get used to talk by themselves and not just having the parents being the spokesperson. So you want to start early, trying to ask the child, what is your understanding of what you have? What are the medications you take? Try to see if they are even ready. And then the other big challenge is sometimes, especially for us that deal with a disorder of gut-brain interaction, is finding an adult practice that welcomes patients with sometimes very severe, functional disorders. As you know from the studies that you have done, there is a bias and there is a stigma, and many adult practices will be just as happy, to do screening colonoscopies and not necessarily have to spend 30, 45 minutes, an hour with patients with complex functional disorders. So, you need to find the right person to refer them to. And then there are all sorts of logistical questions, insurance issues, and coverage, and whether or not they're going to go to college. But I have to tell you, sometimes a change of scenery, a change of environment is beneficial for the child. Sometimes the environment, and when I say environment, I mean everything from the school, the teacher, the friends, the family. There's a lot of pressures, sometimes a lot of expectations. Sometimes just for them to go to college and to live independently for a while is curative.
Yeah.
I sometimes follow them through the first year or two of college, and they come back says, I'm actually well. I've been doing well in the last year or two.
Maybe they're extricating themselves from the home environment and getting peer influence and growing up in that way. The corollary to what you said about finding a good doctor in adult is my observation that when I get referrals from pediatric GI to me, I find that the pediatric GI are much more engaged with the patient than what I would consider a referral from an adult GI, which sometimes is take over this patient. I don't want anything to do with them. But the pediatricians seem to have formed that relationship, and they're in some ways almost protective. And so they're much more willing to talk about what's going on, get on the phone and all of that.
It's absolutely true. In fact, sometimes we have a big resistance from families and children or adolescents who want to stay with our practice, until they are 21, 22, 23, and so on. And sometimes they need to be nudged It's time for you to, this is a pediatric hospital. We deal with babies and young children. You are 22, it's time to move on. On our, just to explain why sometimes pediatric gastroenterologists may seem to have a better relationship with these patients, there is also the fact that in pediatric GI, about 70–80% of practitioners are in academics, and only very few are in private practice.
Yeah.
And I sense that we still have the luxury in academics, or a little extra time, we can still do the 30–45 minutes visit that these patients have. We often have a psychologist, mental health provider in clinic with us that really help us frame the discussion and helps the child get better. While I think in adults it's almost the opposite. I think most 80–90% of people are in practice, and they don't have quite the time to dedicate to more complex biopsychosocial models.
Yeah.
Dr. DiLorenzo, a question for you. As a parent of 2 teenage boys, this is resonating with me, but I'm curious, at what age, let's say you've had a patient since 4, 5, 6 years old, whatever, and now they're 13, 14, is that when you start having the conversation with the parents about what that transition is going to look like, and at what age the child's going to need to transition, and sort of set those expectations? Because as Doug just mentioned, there is a lot more of a hand-holding kind of relationship with pediatric doctors and their patients, and less so in adult medicine. So setting that expectation, I think, is going to kind of help with that transition of care, because my experience in just moving my children on to adult medicine, it's been a completely different experience, obviously. And we're kind of like, whoa, wait a second. We have to really advocate now, and we have to really be the ones that are looking at referrals and asking for certain things, whereas pediatrics was kind of anticipating that on our behalf, and I didn't really have to do as much. So at what age do you start having that conversation?
I tend to do it a little bit later. Very few adult practices will even accept somebody younger than 18. Sometimes they get so picky, even 17 and a half, they will not accept. So I usually do it when they are close to it. And to be honest, we often follow them even when they are first year or 2 in college, depending how far they go. It's interesting because most of the rest of the world, if you talk about the UK, Italy, most of other countries actually transition patients at 14, at puberty. They don't see adolescents. Adolescents are seen by the adult provider. So the US is one of the few countries where the pediatrician with the Academy of Pediatrics actually define pediatrics up to 21 years of age, which I think is the right thing. I think we do a better job with adolescents than our adult counterparts, but I may be biased. But it's a complete different model of care. In fact, if you look at the published studies from Europe, they always have just school-age children. They almost never include, adolescents. It's just a different model.
Very good. Well, thank you. Any other comments, Carlo, that you would want to make that we should know about?
No, it's maybe one more comment is something that has been brought up actually, since we've been talking about the parents-children dyad. We now have several studies from Rona Levy in Seattle and Lynn Walker in Vanderbilt that actually show that treating the parents, giving the parents the tools on how to appropriately respond to the child complaint is just as good and as effective as treating the child. So I think there have been some very elegant studies done in which nothing is done to the child who presents with IBS or functional abdominal pain, and just teaching the parents what to do when the child complains is beneficial to the child. In fact, there was a study actually this month that showed that even for anxiety disorders, just targeting the parental response is as good as doing cognitive behavioral treatment in the child. So once again, this enmeshment, this relationship between the child and the parent is of tremendous relevance and tremendous importance.
Very good.
Wow, that really shows then the evidence of children taking their cues on how to handle stress and anxiety from their parents. So
I tell the parents, your child is much more perceptive than you probably think he is or she is. And they usually respond to that. They usually, after a while, acknowledge it. So if you're really that worried, your child will continue to have a lot of somatic symptoms. So
very, very interesting. Well, that is such good information. Thank you so much for your time today. And hey, if you're watching and you have a question for Dr. DiLorenzo, please let us know. Send us a message or put a little note in the chat there, and we will forward those to him and get those answers for you. So until next time, have a great weekend, everyone. Take good care, and we'll talk to you soon. Bye-bye.
Bye, everybody.
bye.